Hello colleagues, welcome back. Today we are going to discuss about shock. Shock is a common chemical emergence that is always characterized by features of reduced tissue perfusion and multi-organ tissue death. By definition, shock is a pathological state causing inadequate oxygen delivery to peripheral tissues and resulting in lactic acidosis, cellular hypoxia, and disruption in the normal metabolic conditions of the body. Shock is any condition that causes inadequate tissue perfusion and tissue hypoxia. It could be reduced saturating volumes, it could be reduced volumes secondary to impaired pumping, it could also be reduced all those conditions that cause an impairment in the saturation of blood and oxygen to peripheral tissues resulting in shock. Clinically, shock is classified into three types, that is hypovolemic shock, cardiogenic shock, and distributive shock. And distributive shock is further divided into septic shock and neurogenic shock and anaphylactic shock. Hypovolemic shock is always secondary to reduced intravascular volume. This could be secondary to excessive bleeding or hemorrhage. It could also be secondary to chronic blood losses or chronic impaired production of blood or red blood cells. For example, in features of chronic kidney disease, chronic anemia, all those can cause hypovolemic shock or reduction in intravascular volume, and this one results in diminished cardiac output. As you know, the larger the intravascular volume received by the heart is also equivalent to the volume of blood that heart can pump out, and reduction in the cardiac output consequently results in marked reduction in oxygen delivery to the tissues, which consequently causes tissue hypoxia. And the common causes of reduced intravascular volume or hypovolemia may include hemorrhage, loss of plasma secondary to burns. It may also be loss of fluids and electrolytes, even water in diarrhea and excessive vomiting, or even loss of third fluid spaces. Cardiogenic shock, on the other hand, is always secondary to impaired cardiac function that causes reduced oxygen delivery and tissue hypoxia. And most causes of impaired cardiac function include myocardial infarction and pericardial tamponade. On the other hand, septic shock is always secondary to infection, mostly caused by bacterial infections, and this results in sepsemia, characterized by reduced production of endotoxins and exotoxins, which cause impaired cellular metabolism and reduced cellular oxygen consumption, and consequently causing hypoxia. Neurogenic shock is caused by disruption in the sympathetic nervous system, which may be due to pain, maybe secondary traumatic event, or loss of sympathetic tone, as in spinal cord injuries. The pathophysiology of shock may cause hypotension, reduced tissue perfusion, and tissue hypoxia, and as a result, the body responds to cope up with the reduction in that kind of saturating volume and tissue perfusion. And as the body is trying to counteract these effects through its physiological mechanism, there is conservation of perfusion to vital organs, that is the heart and the brain, and as a result, the other organs are sacrificed, or like the distribution of oxygen, nutrients is also reduced. And there is also progressive vasoconstriction of skin, splanchnic, and renal vessels, and as a result, you end up having renal cortical necrosis, which can result in acute renal failure. And as a result, when shock is persistent, when these physiological mechanisms don't cope up or don't counteract the effects of shock, you may end up having multi-organ failure, which in the end can cause hypoxia and acidosis. Clinically, a patient with shock presents with tachycardia, weak pulse, or a thin pulse. They may have reduced blood pressures. Their extremities may be cold, especially if it is not septic shock. The patient may be anxious and sweating. They may have breathlessness, hyperventilation, and tachypnea. And the patient mental status may be in a confused state, or they may even be unconscious. Examination may reveal reduction in blood pressure, especially if more than 1,500 ml of blood have been lost, that is 1.5 liters. The pulse rate may be greater than 100 beats per minute. As you can see from the table, the clinical features or the vital signs may vary with the amount of blood lost. And most importantly, it should be noted that for shock to be diagnosed, the minimum standard for pulse rate is beats greater than 100 beats per minute. And when the capillary refill is more than 2 seconds, the respiratory rate is greater than 20 beats per minute, and urinary flow rate is less than 20 ml per hour. And in the mental status, the patient may have anxious. Those are the baseline, but as the shock worsens, the clinical features also change and they deteriorate. So this table is just basically put there to help you understand how different clinical features can show the extent of shock in which the patient is. Clinically or physiologically, the normal urine output is always 0.5 to 1 ml per kg per hour in a normal human being. The general management of shock, the primary goal in the management plan is to restore oxygen delivery to the cells of vital organs as early as possible. Remember, shock primarily causes hypoperfusion of oxygen and hypoxia, so we are trying to correct that disability and try to correct and bring normal metabolism. So as one of to achieve that goal, one of the mechanism is we monitor the airway and we support breathing, saturation, and if in the case the patient is breathing, we stop the breathing. Fluid resuscitation through administration of intravenous fluid is highly encouraged, especially use of crystalloids, and then head down position to allow blood flow back to the heart, and identify and treat the underlying cause of shock. Then in most cases, transfusion with IV with compatible blood should be done if clinically it can be indicated. Oxygen administration, as we had earlier discussed, so it can be either through oxygen masks and nasal prongs, or if the patient is unable to breathe on spontaneously, a positive ventilation may also be needed. And supportive measures like administration of inotropic agents is advisable. And as you do all this, it is important you monitor the patient's vitals to evaluate whether the patient is responding to the resuscitation measures. And you monitor the heart rate, the blood pressure, you monitor the respiratory rate, and among these, even the urine output. But the most reliable monitoring measure that shows adequate response to resuscitation is our urine output. It gives a very good picture on the response. Even mean arterial pressure that can be obtained from the patient blood pressure is also a good clinical identifier of the patient's response from shock. So we are going to discuss now the major consideration that can be taken under specific types of shock. And our first type of shock is hypovolemic shock. The goal is to restore the vascular volume. We approach as we do in the general approach for shock. You resuscitate ensure the patient is breathing, saturation is normal, urine output is normal. And in addition to all those measures, fluid and blood replacement can be done through blood grouping and cross-matching if clinically indicated. And then you can also give oxygen support. On the part of septic shock, you identify and treat the underlying cause of septic shock. And then in addition to that, you first give prophylactic antibiotics, mostly broad spectrum, identify the underlying cause, and then from there you can give specific antibiotics. And you can also give inotropic support in form of adrenaline to support the heart and dopamine. In addition to that, surgical eradication of the infection focus should also be done. In the part of cardiogenic shock, specific management is through administration of inotropes that support the heart, such as adrenaline and dopamine. In addition to that, you can treat the underlying cause. If it is cardiac tamponade, if it is pericarditis, you treat the underlying cause. For neurogenic shock, pain relief is advisable, as most of these patients they have low CNS autonomic nervous system outflow, second to increase the pain. So you do pain relief, treat the cause, and give supportive measures like inotropes to support the patient. The main complications of shock include acute respiratory distress syndrome, acute renal failure, GIT ulceration, disseminated intravascular coagulopathies, and then multi-organ failures. Thank you for listening in. We hope to see you soon. We hope this presentation has given us some insight about shock. We hope to listen from you. Comment in case you feel something has been left out, and so that we can discuss together and enhance our learning together. Good luck.